Last speaker is Deborah Evans. I'm going to ask you to be brief if you can, because we're running slightly over time. Chief Executive of NHS Bristol.
Thank you. Brilliant. Thank you very much, and thank you for inviting me. You won't be surprised to hear that I conferred with Jan before the meeting, so I won't repeat areas that she's already covered. I was really interested in what Jan and Margaret have said, and I hope that what I'm going to say doesn't represent too much discontinuity from their talks. I'm going to talk about how things are changing in the NHS and what that means for the community and voluntary sector. I'm going to talk about Bristol. I'm going to look for some positives and perhaps some case studies about some of our learning, and I'm going to touch at the end about recommissioning mental health services in Bristol, because it might be quite a useful example. So these are the questions that you wanted us to talk to, and I thought I'd start just by reflecting on today's baseline, and these points are, I think, a tribute to the community and voluntary sector in Bristol, because these are descriptors of how the community and voluntary sector works in Bristol, and I think we are very conscious of the strengths and advantages that you bring to us. So I think we start from a good baseline. And one of the things that we've done in NHS Bristol over the past period is some work around how do we support partners to grow and to provide more services. One specific example of such a piece of work is we hosted a review by Race for Health. It was a peer review about our procurement for services. How do they work? How can they be opened up more? How can we look at the opportunities for community organisations and specifically for smaller organisations? So some of the things that came out of that review, which we have already acted on, have been things like organising speed dating events for people to get together with other people they could partner up with to put in bids for services, looking at buddying between larger organisations and smaller organisations, looking at one thing that we always try to do when we're re-procuring services is look for the opportunities to break services up into what we call lots, i.e. smaller blocks, so that there are opportunities for smaller organisations to come in and bid. And it's not just about something which is so big that only a national voluntary organisation or an independent company or the NHS can bid for. So we've done quite a lot of work around that, and I'll give you some examples. One interesting one is we recommission patient transport services, which is all the non-999 transport to hospital. And in doing that, some of it was actually won by Great West Ambulance Service, who had to reform themselves considerably to win it. But we had a specific contract which was about taking people to and from their renal dialysis. People go 3 or 4 times a week to satellite units all over the city, and that was won by a local taxi company. And we'd deliberately broken the thing up into lots to give that opportunity for smaller bidders. Not a community voluntary sector one in this case, but it could have been. So lots of examples about that, and Jan has already talked about neighbourhood working, and of course quite a lot of the work that we've done and the services that are provided for us are about providing through neighbourhoods and in neighbourhoods. Now the baseline in numbers, this is a bit crude, but NHS Bristol spends about 9 million at the moment in the community and voluntary sector across 71 organisations. Of that, over 2 million is through our Public Health Directorate. That's across 37 organisations, and 30 of them are Bristol-based. So again, showing the examples for local and all sorts of range of organisations there, many of whom, of course, are members of Voscur. Now, this is where the apologies start. This is a gross simplification of the changes in the NHS. So apologies to Andrew Lansley for this slide. As you know, the NHS arrangements are changing comprehensively, enormously. And at the moment, the people of Bristol have all their services commissioned by NHS Bristol. We have a budget of £700 million a year, and we commission everything that people in Bristol need, whatever kind of service it is. In the future, from April 2013, public health, some of it, transfers to the local authority. And I've listed some of the things, not all of the things, but some of the things that that includes. Other parts of public health transfer to a national organisation called Public Health England, which will be an independent agency. Some commissioning, about 70% of what we spend now, including most but not all of children's health services, most mental health services, maternity, most adult services, most older people services, that will be commissioned by what's known as clinical commissioning groups, led by the local GPs. We have a clinical commissioning group for Bristol, and they will be the main point of contact between the local authority and commissioning NHS services. Then there's a thing called the National Commissioning Board, and that commissions all the things in that right-hand box. Essentially, they commission all of primary care, so the GPs themselves, dentists, optometrists, pharmacists, all of that is about 10% of the NHS's spend. That is commissioned through the National Commissioning Board. And then all specialised services, that's about another 10% of NHS spending. And I've listed some renal services, all of neonatology, HIV, transplantation, a whole load of other things. That will all be commissioned at a national level. So you can see that it's a very different set of arrangements than we've had previously. Speeding on. That clinical commissioning group will employ about 25 people. The Bristol Clinical Commission Group will employ about 25 people. 125 people, all our public health people, will transfer to the local authority. And of course, we're reducing in numbers very, very substantially. That's part of the government's programme. So the other people that are needed will be providing what we call commissioning support. And again, this is a busy slide, I won't talk to it all, but it's health needs assessment, it's business intelligence, is about understanding about clinical outcomes, patient experience, and who's using what services. It's about redesigning pathways. If we need to provide care for people who are diabetic differently and better, where's the expert support for that? It's about communications and public involvement. That will also be a national service rather than a local one. Procurement and market management, very important, and that will be part of commissioning support. So it's a very different model where you have 25 people supporting the GPs in Bristol, and they will be having a service level agreement with commissioning support. So Jan said in what she talked to you about that there's a really big issue for local government, which is about competition, and that is absolutely the case in the NHS. We have a new organisation called the Cooperation and Competition Panel, which scrutinises whether we are using proper competitive processes to decide who provides NHS services. So that's very much the issue for us. The government has a policy called Any Qualified Provider, which is where you basically ask a variety of providers to put themselves forward for accreditation. And then any of those who are accredited can offer a service. That is being rolled out through community and mental health services starting in April 2012. We are starting with primary care mental health services, but it includes things like children's wheelchair services, hearing services, podiatry, a whole list of others, and it will be rolled out. So it's very much that model of competition. just thinking about when all of this will happen, PCTs are disbanded in about 17 months' time. So from April 2014, the new model comes into being. Meanwhile, for the beginning of the next financial year, we have to have created commissioning support organisations. They will be at a regional level, and we will be working with them. Although they are regional, they may have some sort of local office, and all our communications and public involvement will go to become part of a national service again from the 1st of April, but there may be some regional presence. As with lots of other things in these changes, there's a lot we still don't know. So a lot of the detail isn't yet there. The local authority has the responsibility for forming Local Health Watch, which is the expression of a public involvement and scrutiny of the health service at local level, and that grows out of Link's service that we have at the moment. So I think what I'm painting is a picture of an enormous transition for the NHS, and an enormous change in the way which commissioners will be able to relate to the community and voluntary sector. As you can see, there won't be one commissioner for Bristol in future. There'll be at least 3, and that's the GPs, the local authority, and the National Commissioning Board, which will have several subsections. I'm coming on to the positives in a minute. So there are some risks. There are some risks in the transition, and one is, just like the local authority, we have a tremendous focus on how to make enough savings at the moment and on efficiencies. We have reduced our staffing by about 25% so far in finance commissioning, and we've got the same amount to go again over the next 17 months. It's a comprehensive reorganisation, and with that, of course, comes tremendous staff turnover and potentially the loss of organisational memory. The positive in this is that the whole of our public health service is transferring intact to the local authority, and they have tremendous depth of involvement with the community and voluntary sector. So there is something, there's something very positive about that change. And also, although there's only 17 months to go, there are 17 months to go, and we're still kicking. We're still doing lots and lots of things. One of the things we are doing is we are recommissioning almost all the mental health services for Bristol. That's about £50 million worth of work. It's probably the biggest recommission exercise that's happened in the NHS anywhere, inspired from local level. Voscur has been very involved in that process so far. We've had a 6-month process of engagement, huge engagement from community and voluntary sector service users and so on. And there will be all sorts of opportunities for providing services for us as that process runs through the next year, over which we'll actually do the recommissioning. As part of that, we are seeking to commission a crisis house for men to follow on. We commissioned a crisis house for women about 2 years ago, and it's provided by NextLink. Many of you will know them, and it's a really classic example of recommissioning and getting a good local, homegrown, well-regarded provider to provide a service, and it's been a great success story. Another great success story is we recommissioned all our community child health services about 3 years ago, £20-odd million worth of work. It was won jointly by North Bristol Trust, the hospital in the north of the city, with Barnardo's. And Barnardo's, interestingly, are changing the culture in the NHS. It's a fantastic example of how you can create a partnership. North Bristol Trust realised that there are a whole load of strengths they had, but lots of things they didn't have. And what they didn't have was closeness to community, ability to do outreach, and understanding of the diverse needs of Bristol's community. They just realised they didn't have them. And so they got together with Barnardo's, and it's not a subcontract. Barnardo's is not the junior partner. They constructed a formal partnership. And everybody tells me, not only have we tremendously improved our services, but we're changing the statutory sector as well in the course of it. So there are some real positives, and I just wanted to end on that very encouraging note.
Thank you very much. Really interesting insight into the very complex changes the NHS is facing and the opportunities, again, that might be for the voluntary sector.